All right, party people, we are back at it with another one. Today, we're going to be doing a little pharm review. Let's jump right into it. So, first and foremost, verapamil is a non-dihydropyridine calcium channel blocker. It acts on nodal calcium channels in contrast to dihydropyridine calcium channel blockers like nifedipine or amlodipine, which act primarily on arterioles. Verapamil is known to cause constipation. You need to especially know this for USMLE Step 2 CK. So you might wonder when verapamil is actually used. While it's not commonly used for hypertension, it can be used for AFib, especially in patients who can't tolerate beta blockers. Just remember, verapamil is a non-dihydropyridine calcium channel blocker. It acts on nodal tissue, and a notable side effect is constipation. Now, as far as the dihydropyridine calcium channel blockers, like nifedipine and amlodipine, these primarily dilate arterioles, which decreases peripheral vascular resistance and blood pressure. To compensate, the heart rate may increase, but unlike verapamil, these drugs tend to cause peripheral edema. This is another high-yield point you need to know. Always check a patient's medication when they present randomly with edema. They may have started nifedipine like a week ago. So here we're going to hop into a little bit more of the advanced understanding. You have to know that nifedipine and hydrochlorothiazide, a thiazide diuretic, are used for essential hypertension, especially in patients without comorbidities like diabetes or cardiovascular disease. The classic case being a 50-year-old dude with isolated systolic hypertension and otherwise everything else in his presentation is normal, including normal labs. That's when you give nifedipine as well as hydrochlorothiazide. Now, dihydropyridine calcium channel blockers can also be used for pulmonary hypertension. So this would include treating the patient with nifedipine and bosentan. Bosentan is an endothelin receptor antagonist. They are sometimes used during pregnancy for hypertension and even in Raynaud's phenomena. This is where vasodilators like nifedipine are preferred over vasoconstrictors like alpha-1 agonists. Beta blockers are a huge topic. So here, beta-1 receptors are found on the myocardium. If you were to agonize these, you would have an increase in contractility. This is known as inotropy. You would also see an increase in heart rate. This is known as chronotropy. Beta-2 receptors are found on peripheral arterioles. To agonize them would be to vasodilate them. If you block beta-1, you slow the heart rate and decrease contractility. Blocking beta-2 reduces vasodilation, which technically decreases arterial diameter, but this is not active vasoconstriction, just lessened vasodilation. USMLE cares more about the basics, such as beta-1 on the heart and beta-2 on the vessels. There's also other functions like insulin regulation. Those are tested more rarely. So a mnemonic for beta-1 selective blockers are drugs starting with the letters A through M that tend to be beta-1 selective, such as atenolol, bisoprolol, esmolol, etc. Propranolol, in contrast, is a non-selective beta-1 and beta-2 blocker. That's the one you must know for USMLE. Now, there are also mixed blockers, such as alpha-1, beta-1 blockers like labetalol and carvedilol. These don't end in OLOL. Labetalol and carvedilol antagonize both alpha-1 and beta-1. So in addition to slowing the heart rate, they also reduce contractility. They decrease peripheral vascular resistance through alpha-1 antagonism. Now, understand that slowing the heart rate increases diastolic filling time. The longer the heart spends in diastole, the more blood it fills into the left ventricle. This increases end diastolic volume, aka preload. While this might increase oxygen demand, the overall effect of the beta blocker is a net decrease in oxygen demand. This is due to decreased inotropy and decreased chronotropy. In one aspect, it may increase oxygen demand, but overall, the greater effect is a net negative on oxygen demand. Now compare this with nitrates, where nitrates dilate veins, they reduce preload and myocardial oxygen demand. There may be a compensatory increase in heart rate and contractility, but the net effect is still reduced oxygen demand. You need to know this. On exams, they may ask you about the slowing of the diastolic depolarization. This just means you're spending more time in diastole. Therefore, a slower heart rate equals longer diastole. Labetalol, in particular, is high yield for 2CK. For aortic dissection or traumatic aortic rupture, it's first line, followed by nitroprusside. Also, just know that you can combine esmolol with nitroprusside. That's another combination that you might see. Beta blockers have other uses too. Topical timolol for glaucoma, for example, where this is used to decrease aqueous humor production. Propranolol is one of those drugs that you will see constantly on USMLE, so you have to know it. It can be used for hyperthyroidism. think of thyroid storm. Propranolol reduces the peripheral conversion of T4 to T3 by inhibiting 5-deodenase. Propranolol can also be used for akathisia. This is restlessness from antipsychotics. Propranolol can also be used for essential tremor, autosomal dominant, bilateral tremor. You'll see that alcohol reduces this tremor, and propranolol can be used for long-term treatment. You can also use propranolol for alcohol-related tremor. So for social phobias such as stage fright, propranolol or atenolol are used. However, for specific phobias such as flying, a benzo is used instead. If they give you a patient with phobia as well as asthma, you have to know that you do not give propranolol to a patient with asthma. Instead, you give them the benzo. Propranolol is also used in hypertrophic obstructive cardiomyopathy. This is used for the reason that it slows down the heart rate and increases preload. If you reduce the left ventricular outflow tract obstruction, you will improve the patient's symptoms. Now, in terms of the effects of a beta blocker, it slows the heart rate and increases diastolic filling. This decreases cardiac output. Blocking beta 2 reduces peripheral dilation, so peripheral vascular resistance increases. However, labetalol is different. Since it's also an alpha 1 blocker, it also causes vasodilation, which decreases peripheral vascular resistance, even though it's also a beta blocker. So they'll test your knowledge of this. The distinction you have to know is that propranolol increases peripheral vascular resistance and labetalol decreases it. In heart failure, the order of which you treat it, you start with an ACE inhibitor or ARB, and this is before a beta blocker. Why? Heart failure reduces kidney perfusion, which activates the RAAS system. Angiotensin II increases afterload via vasoconstriction. If you block the RAAS, this decreases afterload and improves ejection fraction. Drugs they like are captopril for ACE inhibitors and candesartan for ARB. Once stabilized, you can add the beta blocker like metoprolol. Propranolol is not typically used in heart failure. That's another point you need to know. If you're given a beta blocker in heart failure questions and it's propranolol, it's likely an incorrect answer. Metoprolol is also the first-line beta blocker for rate control in AFib. If beta blockers can't be used, you're thinking verapamil as an alternative. Beta blockers can cause depression. You'll see this in psych questions, where a patient is on a beta blocker and now all of a sudden is depressed. It may seem easy, but if you haven't heard this before, you may miss it. So the treatment, although an easy pick, is just to discontinue the beta blocker. Also note, beta blockers can cause sexual dysfunction. In lung diseases like asthma or COPD, you got to be cautious with the beta blockers, even beta 1 selective ones like metoprolol. The reason is because beta 2 receptors are involved in bronchodilation. Blocking it can worsen asthma symptoms. So even in selective beta blockers, you're not completely safe in asthmatics. You have to also know and just remember that beta blockers can worsen psychotic depression. Just another fun fact. All right, that's it for this one. Go crush it.